So this is a long-term NIH-funded multi-center study. It began in 1999 with the NEAD study, and now we're in the MONEAD study, which is a new cohort, an extension of the old study, but a new cohort of women. And the reason we're doing the new cohort is that drug usage has changed for anti-seizure medications from 2000 to now. And so the drugs that are being used now are somewhat different, and several of the ones that were implicated as being having a lot of risk for children, like valproate and phenobarb, are not being used as much. So our intent was to look at what was happening now. And we enrolled the women when they're pregnant and then follow the children out, ultimately to 6 years of age. But this is our 3-year-old initial results from our 3-year-old outcome, where our main outcome was the verbal abilities. And then we also looked at the measures similar to full-scale IQ. And on both of those, we did not find any differences between children of women with epilepsy that were taking these medications versus healthy children of healthy women. And so this is a very good finding to reassure women with epilepsy. We did not find a dose exposure effect, except in a secondary analysis, we found a marginally significant finding for Levetiracetam, but I wouldn't put too much into that now. We need to follow the children further. We need other cohorts. I think the major limitation of this study, even though it's got a lot of strengths, prospective, and we're following all these things during pregnancy and after the birth that are potential confounders and controlling for all those factors. The major limitation is that the cohort is predominantly made up of women that were taking either Lamotrigine or Levetiracetam, or the two together. We have other drugs in there, but they're the majority of the drugs that are used. And so it adds reassurance that those drugs are safe during pregnancy in regards to the children's cognitive behavioral outcomes. There are many of the drugs still we don't know very much about. I would say we have over 30 anti-seizure medications. And of those, there's only a handful, 5 to 8, that we really understand well what their risks, to good or bad, are during pregnancy. And most of the others we don't. And so there's a great need to continue to monitor these other drugs, both in human studies and animal models, to understand the behavioral effects. It is a teratogenic effect, just like you get a malformation from the teratogenic effects of the drugs. So these are one of the most common types of teratogenic drugs that are given to women of childbearing age. And it's a rock and a hard place sometimes for the women. Most of the women cannot just come off the medication because then they have convulsions. The risk for that, for their life and for the baby's life and for their lifestyle and disability and all those kind of things. So we need to be able to use drugs that control the seizures, because that's a risk in and of itself, but also try to understand better what's your risk for children. The other major thing, I think, is that we don't understand the mechanisms completely. And teratogens work on a susceptible genetic substrate, and we don't understand that right now. We have very few clues about what this is susceptible genetic substrate, other than the fact that if a woman takes a drug and they has a baby born and that baby has problems, the risk for the next baby, if she stays on the same drug, is pretty high. It's elevated over the general population of women with epilepsy. But again, the really good news so far is that at least for these drugs that we're looking at here, it shows that women with epilepsy can have healthy, normal babies, and our other findings overall that there were not major complications during the pregnancy. So there is some risk, but it's pretty low in general. It's no reason for a woman not to have a baby if she has epilepsy and is taking medications. She should feel that she can, but she needs to talk to her doctor well before the pregnancy, make sure she's on a safe drug and planning ahead, doing things like taking folate, so that periconceptual folate has been shown to help the outcomes in children of women who are taking anticonvulsant drugs. The 6-year-old results are more indicative of school performance and ultimate cognitive abilities as an adult. We can also do more detailed testing at 6 years of age because the children are more easily tested at 6 than at 3. And so we can look at other things like memory and and attention and executive function, language and spatial abilities. So we'll be able to get a broader array of things. Also by 6, some diagnoses for behavioral problems like autism or may not be present at 3, but then recognized by 6. So most of those diagnoses will be there at 3, at 6 too. So we think 6 provides a very good age for outcome measures that's very predictive of long-term results in the children.